सबमिशन सबमिशन करना है। हाँ हाँ कहाँ सही समझ गया। हाँ क्या। आ रही है यार। हम्म। भाई साहब हो गया ऑलमोस्ट। हाँ सर। गुड मॉर्निंग सर। गुड मॉर्निंग सर। गुड मॉर्निंग। Good morning, sir. Good morning, all teachers. This topic is acute portal pressure reduction by metformin and carvedilol compared to carvedilol alone in cirrhosis, a randomized double-blind study. Thesis guide is Dr. Manoj Sharma sir and Dr. Chitanshu sir. Outlines are there. Introduction, the hepatic venous portal gradient is a gold standard for quantifying portal pressure measured as a difference between wedge hepatic venous pressure and free hepatic venous pressure. The threshold of more than 10 mmHg defines clinically significant portal hypertension that predict varicose development and decompensation. Values more than 16 mmHg are strongly associated with mortality, and more than 20 mmHg predict early varicose rebleed and death. HVPG, a critical surrogate endpoint, more than 20% reduction from the baseline or to decrease less than 12 mmHg. The hemodynamic response is the key therapeutic target. It is predictive of reduced risk of varicose hemorrhage, reduced recurrent decompensation, improved transplant-free survival. Current pharmacological therapies are non-selective beta blocker and alpha and beta blocker, carvedilol there. In non-selective beta blocker, there is a propranolol and nadolol reduce portal pressure by lowering cardiac output, acting on beta 1 and inducing splenic vasoconstriction on acting on beta 2. It is only 30 to 40% patient achieve a hemodynamic response. In carvedilol, there is a carvedilol reduced HVPG by 20.4% versus 12.7% for propranolol, and 64% of carvedilol patients achieved a response. In study carvedilol Reberger et al. In this study, there is a carvedilol achieve a significant higher proportion of HVPG responder. No major increase in the adverse event with moderate dose. In this delta HVPG and the hemodynamic responder more than 20%. In carvedilol are 54%. Various study carvedilol versus propranolol. In this study, RCTs and meta-analysis shows greater HVPG reduction with carvedilol and a higher response rate with carvedilol than propranolol. Need for a additive agent. The limits of monotherapies was carvedilol superiority. A significant problem remains. Two are there: response ceiling and dose ceiling. Response ceiling is 30 to 40% patient are still non-responder and remain at high risk. Dose ceiling is cannot simplify the increase the dose indefinitely due to systemic side effect like hypotension and bradycardia. There is a new agent is address this limitation. There is a act via complementary mechanism target the intrahepatic resistant, which not worsen the systemic hemodynamic like hypotension and bradycardia. There is a study showing metformin reduce hepatic resistant and portal pressure. Tripathi et al. In this study, metformin reduced portal pressure primarily via decreased intrahepatic vascular tone, not through systemic effect. In this study, cirrhotic and metformin. In portal pressure and hepatic vascular resistance, there is a decrease in hepatic vascular resistance and portal pressure, and significantly hepatic NO viability increase. Proposed pathway was metformin activation of AMP activated protein kinase in hepatic sinusoidal endothelial and stellate cell. Second is increased endothelial NOS phosphorylation that cause increased nitric oxide that cause sinusoidal vasodilation. Decrease endothelial 1 and oxidative stress that cause decrease hepatic vascular resistance. No direct effect on hepatic fibrosis or cardiac index. Acute effect of metformin on portal pressure and cirrhosis. In this study, metformin acutely lowered HVPG by 1.2 mmHg compared with placebo without inducing systemic hypotension or changes in the heart rate. Delta HVPG changes to -1.3 plus -1.4. More than 10% HVPG reduction is 38% in this crossover trial study. Metformin, a novel therapeutic agent, in this preclinical rat model significantly reduced portal pressure and hepatic vascular resistance, also attenuated fibrosis and inhibited stellate cell activation and increased nitric oxide viability. In human study, a single 1000 mg of dose shows significant result in reduced HVPG by 16%, and 46% of metformin treated patient achieved a clinical significant response. No adverse changes in systemic hemodynamic response. Rationale for combination therapy is carvedilol established the mechanism of reduced portal inflow primary act by lowering cardiac output and causing splenic vasoconstriction, thereby reducing blood flow into the portal system with additional alpha 1 blocker activity. And metformin lowers the intrahepatic resistance act on the liver itself. It increases nitric oxide viability via AMPK pathway and has anti-fibrotic effect, relaxing the hepatic stellate cell. Lacunae in the literature was no randomized control trial has tested in carvedilol plus metformin versus carvedilol alone for a acute HVPG response. Human evidence for metformin portal hypotensive effect is limited. Dose and timing optimization relative to HVPG measurement are unknown. Acute safety and tolerability of this combination remain uncertain. Hypothesis in adult with cirrhosis and portal hypertension, adding a single 1000 mg dose of metformin to carvedilol 12.5 mg will increase the proportion achieving an acute HVPG response more than 20% reduction from baseline or HVPG less than 12 mmHg at 2 hours compared with carvedilol plus placebo. Aim and objective. Aim to determine whether adding a single 1000 mg oral dose of metformin to carvedilol improves the acute portal pressure response compared to carvedilol plus placebo while maintaining the short-term safety. Primary objective of the study to compare the proportion of acute HVPG responder more than 20% fall from baseline or absolute HVPG less than 12 mmHg at 120 minutes post dose between metformin plus carvedilol and carvedilol plus placebo. Secondary objective are absolute HVPG change at 120 minute, proportion of patient achieving more than 10% HVPG reduction, assess short-term safety and tolerability in map heart rate and adverse event, acute change in the blood glucose, inflammatory and endothelial biomarkers like IL-10, TNF-alpha, INOS and ENOS. Methods are design a single center randomized double-blind placebo-controlled trial on sample size of 72 patients, 36 per group with block randomized method. Inclusion and exclusion criteria. Inclusion: consecutive patient with cirrhosis with presentation with variceal bleed, 18 to 75 years between age. Exclusion: CTP score more than 12, cirrhosis without variceal bleed, metformin or non-selective beta blocker within last 5 days, serum bilirubin more than 3, serum creatinine 1.5. Contraindication to non-selective beta blocker like heart rate less than 60 and hypotension patient, BP less than 110/60, portal venous thrombosis, SCC and hepatic NCAP grade 2, 3, 4. Outcomes: primary endpoints are acute hemodynamic response at 120 minutes defined as HVPG reduction more than 20% from baseline or absolute HVPG less than 12 mmHg. Secondary endpoints are composite of efficacy and safety measures, absolute and relative change in HVPG proportion achieving more than 10% HVPG reduction, safety of the MAP, heart rate and adverse event, exploratory biomarkers IL-10, TNF-alpha, INOS and ENOS. Intervention done: expected hemodynamic effect on the moderate HVPG reduction is 20% and greater HVPG reduction adding carvedilol plus metformin 35 to 40% and higher hemodynamic response rate. The study design: baseline in the eligible patient screen for the baseline HVPG measurement performed, randomization with 1:1 in double blind fashion. Yes.
Just don't rush through these slides. Just
Yes,
say your thesis, is your work.
Yes, sir. Yes.
Explain.
Sir, sample size in the group 1 and group 2, 36 and 36 patient. Intervention administration was single oral dose carvedilol 12.5 mg with plus placebo tablet with single oral dose carvedilol 12.5 and metformin 1000 mg tablet. Expected hemodynamic effect: moderate HVPG reduction equal to 20% with the greater HVPG reduction 35 to 40% and higher hemodynamic responder rate. Study design: there is a baseline eligible patient screen for HVPG measurement performed with the randomization of n equal to 72 patient randomized 1:1 in the double blind fashion with intervention arm A and arm B. Arm A carvedilol plus metformin, and arm B carvedilol plus placebo. Endpoints are repeat HPPG measurement performed at 120 minute post dose to assess response. Sample size estimation. Randomized double-blind placebo-controlled primary endpoints are proportion achieving hemodynamic response more than 20% HVPG reduction or HVPG less than 12 mmHg at 120-minute post-intervention. Expected response with carvedilol plus placebo is 60% based on the prior hemodynamic studies. Second, carvedilol plus metformin expected response is equal to 90%, absolute difference of 30%. Type 1 alpha era 0.05 and 1 minus beta 0.80, 80%, with allocation ratio 1:1 and total of 72 and 36 in each arm. Blinding was done. Study type single center, double blind placebo controlled trial with allocation ratio 1:1 with block randomization method generated using computerized sequence with randomization list and maintained master allocation codes in the secure file, responsible for ensuring allocation concealment, decoding only after database lock or medical emergency unblinding. Prepared and dispensed identical appearing tablet metformin 1000 milligram or placebo in sequentially numbered opaque envelopes. Performed HVPG measurement and administered carvedilol plus minus blinded intervention. Remain unaware of assignment. Permitted only emergency unblinding permitted only if required for the patient safety. This is the consort diagram. Inclusion criteria. There is a cirrhosis of with acute varicose bleed, and it's equal to 72 with HVPG measurement in group A, metformin plus carvedilol, acute HVPG response assessment after 2 hours. With primary endpoints, acute hemodynamic response at 60-minute defined as a HVPG reduction more than 20% from baseline or HVPG less than 12 mmHg. In the second arm, carvedilol 12.5 mg with placebo. Second, HVPG response assessment after 2 hours with exclusion criteria. With analysis, statistical analysis, baseline parametric data were expressed as the proportion mean plus minus standard deviation and median with interquartile range whenever appropriate. Paired t-test was used to compare the change before and after the intervention. Pearson correlation test was applied to assess correlation between variables. Multivariate logistic regression analysis was performed to identify predictor of transplant-free survival. The p-value less than 0.05 was considered statistically significant. A result of the thesis was there is a multiple variable. There is no significant in the age, height, weight, BMI, female, male, etiology, ethanol, Hep B, SCV, mesoid cryptogenic and Wilson disease, comorbidity, diabetes, and hypothyroidism. No such significant in the carvedilol and carvedilol metformin group. Baseline characteristic is also not significant, sir. Baseline characteristic of systolic BP, diastolic BP, mean BP, heart rate, free and wedge, IVC pressure, RA pressure, PA pressure, PCWP, and RPS, not so significant in this study. In this primary hemodynamic response based on HVPG reduction.
What is your inclusion criteria? Go back.
So, cirrhosis presenting with varicose bleed 18 to 75 years age.
All of them had an HVPG of 85, a map of 85. How many had ascites?
Ascites are
Show me ascites. नहीं ascites था उनको नहीं था.
सर ascites का नहीं लिखा सर. In between
And
थे
they had a map of 85. Go back. Where is the map value? Okay, go ahead. नहीं मैप था ना पिछले वाले में, इससे पिछली स्लाइड. So map is 85. These patients.
around sir CTP is 7.8 के बीच में ही सर. Decompensate only acute varicose bleed.
Yeah. Yeah.
Since one of the drug was carvedilol 12.5 milligram, which is quite a high dose.
So
we
this
had
is
actually-
baseline before
Yes.
carvedilol
Yes, sir.
and before combinations.
So we had taken the slightly higher map because they were to receive a high dose of carvedilol. So the BP less than 110 by 60 was excluded.
Did patients with ascites excluded?
They
No.
were not excluded.
So you should mention how many had ascites. Go ahead.
In this primary hemodynamic response based on HVPG reduction, there is on carvedilol plus placebo group, there is a 63.9% more than 20% reduction or HVPG less than 12 mHg. In carvedilol and metformin group, there is a 88.9% reduction in more than 20% reduction in HVPG response and or HVPG less than 12 mmHg. This is
Go back. इतना तुम्हें जल्दी क्या है?
yes, yes.
So what was the baseline HVPG in them?
So baseline HVPG
रिडक्शन हुआ ना तो
Yes.
बेसलाइन कितना था इस ग्रुप में
1919 sir.
सो 19 से लेस देन 12 आ गया
Yes.
in how many? Go ahead. In 63% you were able to achieve a 7 millimeter reduction.
Yes,
Am I right?
yes sir.
And in the other group in 80% you were able to achieve.
So it will come later, sir. After
Okay.
the actually could receive less, could get less than 12, it will come later.
Go ahead.
Primary hemodynamic response based on HVPG reduction, more than 20% HVPG responder between groups. More than 20% HVPG responder. There is a 50% and carvedilol plus placebo group and carvedilol plus metformin group 86%. And 18 and 31, sir. In the second patient, achieving post HVPG less than 12 mmHg reduction, achieved is a carvedilol in the 22%, 22.2%, and carvedilol plus metformin 58.3%. Significant drop with carvedilol plus metformin. Percentage reduction in HVPG between the two study groups. There is a delta HVPG percentage reduction. Its group 1 is 20.24 plus minus 15%, with carvedilol plus metformin group 36 plus minus 24%. Mean difference of plus 16.6% mean difference with
A
significant.
very huge SD. We try and do medians. The SD is very high. Go ahead.
More than 10% HVPG reduction in carvedilol plus placebo group, there is a 88.9% and carvedilol plus metformin 94.4%, more than 10% HVPG reduction in the carvedilol plus metformin group, more than 10%. Primary hemodynamic response based on HVPG reduction. There is a HVPG baseline is 17.97 plus minus 5, and group 2 carvedilol plus metformin 17.3 plus minus 4.18. In HVPG, post HVPG, there is a reduction in the 14 plus minus 4.34, and in metformin group, there is a 10.72 plus minus 3.93 with a significant mean difference of 3.28. With delta HVPG, there is 3.97 plus minus 3.26 with 6.61 plus minus 4.37. There's a mean difference of minus 2.64. With significant drop in the carvedilol plus metformin, sir. Changes in the systemic and hepatic hemodynamic parameter, there is a no significant value in the systolic BP, diastolic BP, MAPE, heart rate, free HVPG, HVPG, IVC, RA pressure and PA pressure, sir.
What happened to free hepatic?
Yes, sir.
Free hepatic.
It's a baseline, sir, pre-hepatic.
Has it risen after giving carvedilol and metformin?
So pressure decrease.
Pre-hepatic, did it increase or no? Look into pre-hepatic may rise in these patients.
So there was mild increase in the free hepatic pressure, and majorly there was change in the wedge pressures. And this change was less in the carvedilol arm compared to the metformin plus carvedilol arm. So the delta FHVP and delta WHVP is actually not different in between the two arms, but individually. But when these two factors are combined, then HVPG becomes significantly different between the two.
Free hepatic will help you in finding the mechanism of action of metformin.
Yes, sir.
So that you should look into free hepatic.
So there is slightly more increase in the free hepatic pressures, slightly more increase compared to the carvedilol arm.
Okay.
Changes in the random blood sugar, sir, not significant in the both the arm carvedilol and carvedilol metformin, so pre and post, sir, with baseline of 101 mg per dl with 116 mg per dl with carvedilol plus metformin. Post there is no changes, 93 and 95 plus minus 29 with no difference, not significant, sir, changes in the RPS, sir.
Show the blood pressure, pre and post, group A, group B blood pressure.
Sir, this one, sir.
Yeah.
Systolic and diastolic, sir.
So diastolic also got reduced. MAP is increased. How did MAP increase? There is a MAP reduction. Is that MAP reduction or what?
No, sir, slightly reduction in the MAP, sir.
6.5 and 10 MAP reduction. If MAP reduction, then there is more vasodilation.
No, sir. Delta MAP, sir. 6.5 and 10.
Did you calculate the cardiac output?
No, sir.
You should have calculated the cardiac output and systemic vascular resistance and pulmonary vascular resistance. That would have added value. Which circulation is more affected by metformin? If you have the ABG, you can calculate still. Okay.
Carvedilol remains the backbone of the pharmacological portal pressure reduction through beta alpha blockade. Metformin via AMPK mediated endothelial and sinusoidal vasodilatory effect augment intrahepatic resistant reduction. And combination demonstrate a synergistic metabolically neutral hemodynamic benefit. With carvedilol plus metformin provide a stronger acute total patient lowering effect than carvedilol alone. Response is hemodynamically significant, safe, and mechanistically rational. This finding warrants a longer-term multicentral trial to confirm sustained HVPG and clinical outcome benefit.
What are the limitations of this study? What are the future? What is the limitation of your study?
Limitations are there is a inflammatory markers are awaited, sir, in this.
Go to your secondary objectives.
Secondary,
Where are these IL-10, TNF?
sir, awaited is in the lab, sir, markers.
ENOS, INOS तो instant होते हैं भाई, lab में थोड़ी जाते हैं. They are done within 60 milliseconds. All the nitric oxide is finished in 60 milliseconds. So it's not seconds. But you can do IL-10, TNF alpha. Certainly can be done. Well, my comments are it's a very useful study, but unless you have mechanistic basis, how just giving one metformin tablet of 1 gram will deactivate stellate cell in a patient with fibrosis and cirrhosis is a huge challenge. You're deactivating stellate cell. So mechanistic part is required. And any comments from Chitranshu before?
Actually, sir, when one of the drug is carvedilol, then it is difficult to achieve a added response or superior response by adding any other drug because it itself has got a very profound effect. But since the mechanism of action of the two is different, it is metformin acts through the AMPK pathway, subsequently cyclic GMP nitric oxide. On the other hand, carvedilol acts through the protein kinase C, cyclic AMP, and calcium-mediated pathways. So the effect may be synergistic or additive when these two are combined. And we only know the acute HVPG response as of now because of the shortage of the time that was given to him, because this thesis was given lately to him. And whether this benefit is sustained over the long term, whether it evolves into the better patient outcome in decreasing the mortality and improving the decreasing the decompensation rate, that needs to be seen in the future. Sir.
The other odd point is you have 58% of patients who had alcoholic cirrhosis. Only 58%. So it means metformin works in alcohol patients also, which is very good idea. I mean, if you can do subgroup analysis between MESLD or MAFLD and alcohol and see what the benefits are between the two groups. Suppose the MAFLD group has much more benefit than the alcohol, then it's a different path. But it's interesting. Any other comments from? Proof of concept. I also want on this paper, this page, this. Can you go to your hypothesis one more time and tell us proof of concept? Garbis was never ready for all these questions, I know.
We're the only ones who can give us this now.
Yeah,
That's right.
tell us
Proof of
hypothesis and what is the proof of the confirmation of your hypothesis. In the hypothesis, you have not mentioned how metformin is likely to work.
yes, sir.
How?
Don't know the
अरे भाई तुमने हाइपोथेसिस लगाई है ना,
हाँ सर.
तो बताओ कैसे काम करेगी दवाई?
Likely, sir, lowers the intrahepatic resistant,
How?
increase the nitric oxide viability and increase
Metformin.
sir.
Metformin, how will metformin help you? The whole thesis is based on.
Yes, sir.
स्लाइडें क्यों जंप करा रहे हो तुम? How? Just tell us without looking at slide. What was in your mind when you gave metformin? What was your hypothesis?
Sir, adding the metformin decrease the intrahepatic resistant flow.
How? There are two pathways. One is nitric oxide, one is AMP kinase, which deactivates stellate cell.
Yes, sir.
But in patients who already have cirrhosis, they have stellate cells which are converted into myofibroblasts. These stellate cells are hard. They are not those fresh, quiescent which became active when you deactivate. They are. So how will metformin work? And endothelial cells are also damaged. They are not that contractile endothelial. They have lost their pores and they have lost their, perforators. So how will that work? But the effect is clear.
Yes,
Because we have one thesis by Tanmay, and Tanmay's thesis also, portal pressure came down from 18 to 11 or 12, and we were surprised. 60% of the patients in Tanmay's thesis also showed more than 10% reduction, and I think 20% had more than 20% reduction. The same you have reproduced, but the question remains, how does it work? So maybe more mechanistic. So Seema's question is the proof of concept.
Liver biopsy would help, sir. Or
Liver biopsy, but not single dose. This is an acute study of 2 hours. But Chitranshu, you're the guy. Tell us. Chitranshu is master in hemodynamics. Chitranshu, tell us.
While evaluating the acute HEPG response, we can only see the the dynamic component of the HEP, the portal pressure, not the static component. And the stellate cells are themselves contractile as well. Apart from leading the fibular matrix, they themselves are contractile, and the metformin will increase the local nitric oxide levels and then causes vasorelaxation. And it is that component that we can evaluate by this acute HEPG response study.
By any chance, you have the blood samples of these patients pre
Yes, sir,
and
we have got,
post?
sir.
Yes, sir.
So very easy to do 1 Willebrand factor, which is a direct reflection of endothelial contractility. Do 1 Willebrand factor and ADAM-TS13 and the ratio.
Yes.
And if there is any change in the platelet number or function, so that will give you an idea of endothelial contractility, endothelial viability, and response to metformin. So please do ADAM-TS 13, 1 Willebrand factor, and platelet aggregation.
Yes.
You can do vitro test. Any other comments?
Chitranju,
Very good.
Chitranju, Garvit, nice actually. I'm just bit, you should have got a smart diagram on mechanism so that you wouldn't have struggled in explaining all this.
Yes.
No, that would have been good. So basically what you guys are trying to tell us that metformin decreases nitrous oxide level. And that was the reason why HPVG comes down, right? That the whole mechanism. So are there any other drugs which do same thing, or this is just with metformin?
Other is
So
also
if you have other drugs, there are drugs which are known to decrease nitrous oxide level. So are there other drugs known to do the same?
I think, sir, maybe
What are the other NO donors?
hydroxide,
Simple nitrates. You give nitrates, but nitrates are ugly. They are bad drugs because they will also dilate the renal system. So if you give something like sorbitrate or those, so they will not only dilate portal system but also renal. You get a decrease in the renal blood flow in patients. So it's contraindicated.
Yes, that's what it is. Sorbitrate is.
Earlier, nitrates used to be given as well. There are earlier studies
Earlier.
using nitrates as well, but
Yeah.
they cause systemic hypotension. So they used to be poorly tolerated.
That is what. So that's the old fashioned teaching actually, where directly actually acting on nitrous oxide is more trickier than actually having something which comes indirectly, right?
So nitrates decrease the portal pressure by 7%, propranolol by about 15%, carvedilol reduces by 46%. So the benefit of carvedilol over any of these is immense. But if you combine nitrate, if you just give nitrates, they are bad for us.
So can you not do blood on gas nitrous oxide level?
Yeah, you can do on the spot, or you can.
So we have to
When you're doing HPVG, you can take venous sample from the veins and then look at that.
So the kit has been procured, and we are going to run the samples, sir.
Can I ask one more question? So all this need to translate into rebleeding rates as well, isn't it? Because the whole idea of decreasing portal pressure will be that patient should not bleed again, right? So have you looked at this, that what was the incidences of rebleed rate after doing all this?
The acute HEPG response study. This needs to be further studied, whether the chronic response is sustained or not, whether the patient really benefits with this or not, sir.
Yeah, because that's important, isn't it? Because acute HPVG response can be because of lots of things which has happened to the patient during the bleed process, right? Different patient may behave differently with the bleed. But the whole idea will be to give this two drug will be long-term sustained response and rebleed rate, isn't it?
Any other comments? Since we have time, I would certainly like, as Vinend also says, a long-term study planned after this. We have done with Tanmay, and we had done liver biopsies, but biopsies were done only 3 out of so many because repeat biopsy was not done. But I think now we have many soluble factors which can, like ELF. So if you do it, and you can see reduction in ELF, you can see that there is a reduction in the inflammatory markers which should be done. I think we can go ahead. This is a new breakthrough. using metformin for short-term studies.
What about splenic stiffness, sir?
That's a good question. Splenic stiffness. You can do acute splenic stiffness measurement, SSM, along with which is there is a reduction of 10 millimeters or 8 millimeters in HVPG. It will reflect in splenic stiffness. It's a very good idea. You can also do blood flow because flow and pressure both will determine the resistance. So you can do that.
So metformin in acute response also very rapidly modulate the mitochondrial function. So it is a good modulator of AMPK, and then so that could be the reason that your metformin has a lot of function, but in mitochondria it gives a very rapid response.
You can also do mitochondrial function. You can take the cells and pre and post, and you can do mitomass, the amount of mitochondrial mass, mitochondrial function, mitophagy. All that can be studied in the on the seahorse that Anupam has. It can easily be done. Okay. Well, thank you, Garvit. Thank you, Chitransh.
Person who was.
Any who is supposed to present?
Anmol, my department, he's gone to recently, sir. He'll present in the subsequent 2 weeks.
Okay. All right.